that we have been doing conferences, courses, or conferences, but the bigger conferences, the budding surgeons didn't get any platform during the cases, and this way learning was a little hindered. So these are initiative, and other states like Telangana has been doing very well in BIS. So without wasting time, we just promote all the states to come and do BIS webinars like this. Now I request our state coordinator, Dr. Kuldip Parmar, to start the webinar.
Thank you so much, Shamshul sir, for giving this opportunity for Gujarat state to present a webinar. And I am very thankful to our Amar sir. And under his guidance, I could able to go through the cases, and being sir said, go with the simple cases rather than a complex case. And so we started with let us go with the fracture. I will introduce everyone to the faculty we have. We have the senior most and the leading surgeon, sir, Dr. Ajit Patel sir. And pardon me and everybody, sir name is Ajit Patel sir and not Patel sir. Gai mein maine locha kiya thoda, but I am very sorry to sir, and please the community, it's Ajit Patel and not the Patel. And he is practicing in Baroda since mid-90s, and he is being excellent in trauma, reconstruction, high tibial osteotomy, and other things. My colleague Shaurya is practicing in Junagadh. Shaurya is practicing also in Baroda along with Godbole sir. Armish is practicing in Junagadh and Saurashtra region. Myself practicing in Rajkot as a Ilizarov surgeon. And keeping a seminar simple and interactive. Also, not taking much time, we will directly jump on to the lecture. So the basic aim for the today's seminar is the fracture fixation. And that may require transport, that may not require transport, but that is how we are going to go on. And I will request our senior most faculty, Ajit Patel sir, to go on with their lecture. Thank you, sir. Sir, unmute yourself. Ajit sir, unmute yourself.
Yes, I'm audible now.
Yeah, you are audible, sir.
Okay, thank you, Kuldip. And I'll start sharing my screen. Okay, I think now the screen is visible. Okay.
Yes, sir.
So I'll start with the talk. First of all, I'd like to thank the ASAMI India team, Dr. Rajat, Dr. Jayant Sharma, and Dr. Shamshul, and especially also the Gujarat state team with Dr. Amar and Dr. Kuldip for inviting me for this talk. And since this is a session which has been specially designed for budding Ilizarov surgeons, I have selected a talk of simple close comminuted upper tibia fractures. Probably this is the most commonest indication a budding Ilizarov surgeon will come across and can start off with and give a good results in his practice. So with this introductory thing, I'll start off with my talk of upper tibial complex upper tibial fracture. And as soon as a complex upper tibial fracture comes, we have been trained to think like all the classifications, Satzger and all other column classification, everything, which is totally dependent on geometry. And we start thinking of which type of plate it will be, we will be fixing. It will be an anterolateral plate, posterior plate, or raft plate, all those things. So everything runs on a geometry of a fracture in our mind, subconsciously. But upper tibial complex fracture is not only a fracture geometry, it is a soft tissue injury also. And most of the complications that come across in this region are because of the soft tissue injury. So it is actually a complex upper tibial injury. And I'm going to talk of role of Ilizarov fixator, as they call it in West, thin wire fixator, because I don't know what the hatred for, what is the phobia of calling it as a Ilizarov fixator, but they call it as a thin wire fixator in a complex upper tibial injuries. So upper tibial injury, the goals which we have is congruity, range of motion, stability, and axis. These are the common goals. These goals are defined, whether we do it by Ilizarov or we do it by internal fixation. These are the common goals that we are going to achieve. We also know the problems. The problems are soft tissue, the fracture geometry, and the quality of bone. This also remain common, whichever methodology you are going to do it. And historically, if we see, this is like, it started with conservative. It went on to acute open reduction and internal fixation with humongous amount of complications coming into the society of these fractures. And then came the stage protocol. As we all know, the stage protocol, and there are different stage protocol for open fractures, but I'm not covering that. I'm just going to talk of closed fractures and application of a bridging external fixator, let the soft tissue settle, and then go for the definitive fixation. This was the stage protocol, which was mainly designed to decrease the number of complications open reduction had. And it does decrease the infection rate. There was a lot of decrease in infection rate after the stage protocol, but it added certain things. There was a dual stage major surgery. It was the indirect reduction started becoming more and more difficult after 1 week. There was increased quadriceps inhibition and knee stiffness, and longer non-weight bearing Peter, and delayed functional recovery. So these were the disadvantages of stage protocol. Now, there were certain biomechanical disadvantages of internal fixation, and they reported higher subsidence rate of medial condyle with lateral locking plates, and with dual plate, there were a lot of infections. So if we see the complications, this is a study from a level 1 trauma care center. It said 22% post-operative malalignment. So there was a malalignment right from the go, the fixation was done. And the commonest was hyperextension. There were 22% rate of deep infections, 8% loss of alignment into varus. There was other complications like delayed wound breakdown, hardware irritation, compartment syndrome. So there was upper tibial fractures in spite of stage protocol was going through a lot of complications. Now there is another important analysis, MRI analysis of a complex upper tibial injury, which said that only 1% of patient had no soft tissue injury. 77% patient had complete tear of collateral or cruciate. 91% had a lateral meniscal injury. 44% had a medial meniscal injury. 68% had one or more posterolateral structure injury. The clinical importance of this is still not analyzed in literature. In an acute situation, what this soft tissue injury translates into the result is still not analyzed in the literature. And that's why the treatment protocol in an acute scenario of soft tissue has no consensus till date. So present scenario in a complex upper tibial injury is goals are defined, the problems are identified, the stage protocol, a Western concept, has been copied, but the complications still are high and hurting. So, and ligament injuries still remain unsolved. So, with this background, I'll try to introduce Ilizarov Fixator for complex upper tibial injury and how I use it. The indications, high energy Shatzer 5 and 6, the commonest indication, because if you are going to use in a low energy, you are going to get result, but low energy has a lot of internal fixation options also. Where Ilizarov scores above the internal fixation is in Shatzer 5 and 6. Open fractures with soft tissue loss, open fractures with bone loss. These are like undoubted indications. The principles is ligamentotaxis, reduction of diaphragm fragment, counteropposed olive wires for intercondylar reduction, lateral stability. Now, lateral stability is a concept which came in internal fixation very late. Ilizarov was trying to give this lateral stability in upper tibial fractures for long back, right from the beginning. So lateral stability is very important, restoration of axis and traction. Now, this is a very important thing that I'm talking. See, we had been doing our age-old days, treating these fractures with traction, and we were getting good results. It was not that all the results were bad with traction only, and traction had certain advantages. The traction was doing very good things to the soft tissue injury, which was there in an acute scenario. And it used to settle the soft tissue. Once the soft tissue settled, it used to give stability. So I have incorporated a traction for soft tissue injury in acute scenario for a limited period of time till the soft tissue settles, and a supervised rehabilitation. So these are the principles. I'll go to the surgical technique in bit detail because this program has been designed for the budding Ilizarov surgeons. So first of all is traction, which goes with a ligamentotaxis. And usually, what is the timing? You try to do it within 5 days, because with this time, the best way is to get good ligamentotaxis and indirect reduction. This is the position. I'll just try to explain in detail why this position has been designed. A calcaneal wire traction on a leg holding frame with 30 degree of flexion. Now, this is the best position to get good ligamentotaxis and a good alignment in AP and lateral view. Because otherwise, what if you do it the same thing, reduction, you do it in a fracture table in full extension, you're likely to get a hyperextension malalignment right from day one. And it is very difficult to correct that hyperextension malalignment because the proximal fragment is too small. Now, there are a lot of dipunch fragments in such type of injuries. The one word of caution is, while handling this dipunch fraction, you should be very careful. Handle them very, very delicately. Try to get the articular reduction as good as possible. See, mark my words, as good as possible. We should not be like totally obsessed with getting an anatomical articular reduction, because no literature ever has yet proved that anatomical reduction with less than 1 millimeter gap is less than 1 millimeter step is going to give good result. The only literature which has been proved till date is good anatomical alignment of the whole limb and a stability of the joint gives good results. So all this blah blah of 1 millimeter step has still unproved in the literature. So this lifting of this dipunch fragment can be done with a small ST pin or a subcortical window with a bit RT process or any pusher like blunt thing, and you get as much as better subarticular reduction as possible. Now, planning of the proximal wires, this is also very important. Once you are like experienced, you can plan this with only excess study, but CT scan can give you a better plan of action on how your wires will be placed in the whole upper tibia. Now, where to put, once you have put a traction, where to put the first reference wire? Sometimes what happens is once you have put a traction, you get a reduction, but not all fragments are reduced, and you still want to put a reference wire. So you want to put a reference wire parallel to knee joint. So which fragment? So you will select a fragment which is most anatomically aligned and put that wire through that fragment, and it should be around 1.5 centimeter distal to knee, so that it is away from the synovial reflection. It should be anterior to the fibular head, and with that, and what you start fixing the ring, this wire should remain superior to the ring. Now, this metal ring can give you sometimes imaging difficulties. In those scenarios, you can use a carbon fiber ring. The second reference wire will go to the parallel to the ankle joint. It would be around 2 to 2.5 centimeter proximal to the ankle joint and anterior to the fibula. Now, a pre-assembled frame of 2 rings is fixed to the second wire. So you have now one parallel wire to the knee, one parallel wire to the ankle. And at this stage, it is very important to see that there is a centralization and a rotational alignment of both the rings. The proximal ring is centralized and rotationally aligned with the center of patella. The distal ring is centralized and rotationally aligned with tibial crest and second toe. Once these are tension, you can't interconnect hole to hole, and you keep it distracted by 3 to 5 mm. So you have some space for manipulation and you get maximum ligamentotaxis. At this point, you reassess the reduction. You reassess the position of the middle ring. It is properly placed as compared to the fracture site, and the intercondylar reduction is achieved when you assess the metaphysial-diaphysial reduction in your AP plane and a lateral plane. So the intercondylar fragments are reduced by the counter-opposed olives like this, and you can change the direction of the olives as per your CT picture from posterolateral or posteromedial as per the bigger fragments. Now the middle ring olive wire can be placed as per the displacement. If the distal fragment is displaced laterally, it will go from lateral to medial. So you can translate it and get it reduced. You assess the reduction in lateral also. If it is a posterior sag, then you can arch that wire to get the reduction in lateral also. And after this reduction is completely achieved, you add remaining wires at each level, preferably in a proximal ring at least 4, preferably 5. In the middle ring at least 2 wires, a distal ring 3 wires. You can use even half pins if you are comfortable with half pins also. So we just revise again the frame again, because this is absolutely like we are going in for the budding surgeon. So we'll revise the construct of the frame. The construct is always below knee, preferably when I go above knee. Once the whole fixation is done, and if I find there is a huge amount of instability amounting to subluxation of the knee joint, if I am finding that much amount of instability, then only I go above knee. Otherwise, I always keep it below knee. The timing, preferably within 5 days, as I said. Traction, ligamentotaxis. I'm just revising this. Position, calcaneal wire traction on a leg holding frame like this. Dipunch fragment by joysticking, push screw, or submetaphyseal cortical window like this. Reduce the intercondylar fragments with counter opposing olive. Diaphysiometaphyseal reduction to get the good axis. And lateral stability can be achieved by holding the fibula proximally with the olive wire. Now we go on to the post-op protocol. Once you have done a good fixation, it always requires to give a good functional result, a good post-op protocol. Now, I had said initially that I sometimes use traction. When I use traction, when I find that there is a mediolateral or anteroposterior instability, not amounting to subluxation totally, where I usually go for a above knee frame, but if it is just instability, there is a soft tissue injury, some instability, I will give traction up to 3 weeks. It may not be till the soft tissue settles. See, sometimes what happens in these patients, apart from a collateral injuries or a meniscal injuries, there is an impact injury to the cartilage also. Now, impact injuries to this cartilage, they give a lot of inflammation. And we have been like tuned to do early mobilization by the platers and internal fixations. But in a high energy trauma, the scenario of soft tissue and cartilage damage is different as compared to the low energy trauma, where usually the internal fixation works better. Okay, but in a high energy trauma, there is a lot of impact injury to cartilage. There is a lot of soft tissue injury around the knee, and you require some time of rest to allow these things to settle. So what is the best position for them to settle? You give a traction in straight limb, okay, for 10 to 20 days as per the requirement. And during that supervised one, you can start quadriceps, static quadriceps, ankle stretch and dorsiflexion exercises. And sometimes this ankle and dorsiflexion exercise, ankle dorsiflexion can be active and active assisted. So this will reduce, see what happens in upper tibial fractures, there is a lot of hematoma formation in the posterior aspect. And posterior aspect hematoma, a deep muscle compartment hematoma starts organizing after 2 to 3 weeks. So before it starts organizing, you have to release. Otherwise, what will happen? These patients go for a delayed equinus deformity. Why they go for delayed equinus deformity is because this hematoma, which is formed in the deep posterior compartment because of the injury, it starts organizing, it starts fibrosing. And once it starts fibrosis, it is very difficult to correct that equinus. So you start this ankle dorsiflexion exercises from day one, pumping exercise. It will prevent the deep vein thrombosis also. It will give good relaxation of posterior muscles. And a supple ankle will help in his gait in long term also. And after 10 or 11 days, once the quadriceps is there, you can start active assisted knee flexion with traction. Now, this is like somewhat like active assisted means it is gravity eliminated. The patient pulls the thigh with the traction, and this is gives the effect of a CPM kind of thing to the joint. So whenever there is an impact injury to the cartilage, it settles and it resurfaces properly. So follow-up rehabilitation would be once after the soft tissues are settled, cordyceps is regained, these patients start doing active SLR anywhere between 4 to 6 weeks. That is where the time when I start high sitting. I don't start high sitting till a patient is doing active SLR. And weight bearing usually starts between 6 to 8 weeks, depending on the combination, intra-articular combination that I am dealing with. And the frame removal, as the weight bearing patient reaches over a full weight bearing by 12 to 16 weeks, and there is the radiological union. So a frame removal usually happens between 12 to 16 weeks in these patients. So we'll just run through a few cases in this scenario. I'll be just concentrating on closed fractures because open fractures people are presenting the cases. And I think closed fractures is the commonest indication a budding surgeon is going to get. So this is like type 6, less comminution, but intact fibula. This is the CT picture. This is how the reduction has been achieved, a good anatomical reduction. There is a severe subchondral and metaphyseal comminution. You achieve good reduction as per the technique I have and steps I have said. Union in 4 months. This is Sadker 6. Again, there's if you see there are 4 fragments in the process, all of them reduced properly with this. Otherwise, you will have to use at least minimum 2 or 3 plates in such type of fractures. Compression at diaphysiometaphyseal junction can be done with maintenance or articular reduction. And now this is a very different scenario, a small proximal fragment with a recurvatum type of deformity. Now, this reduction is very important to get in a lateral plane. And holding of this small fragment, Ilizarov Fixator is the best way to hold this small fragment and correct that recurvatum deformity and get a good alignment in lateral view also. This is 3 months post-op, and this is the reduction and going. So when there is a severe diaphysiometaphyseal combination, in that also this system works very well because people are trying to do it with plates and nails also, but the complication rate are still high of delayed union, non-union, and Ilizarov probably is a better option. This is post removal. And now subchondral metaphyseal and diaphysiometaphyseal combination. Now this is how percutaneous manipulation of diaphragm fragment can be done, and you can get a good anatomical reduction of the articular surface as well as a good diaphysiometaphyseal reduction. And this is some severe type of combination of Sadger 6 type, and probably a reasonably good aligned articular surface and a metaphyseal reduction. This is 2 months post-op. This is 3 months post-op. This is 8 months post-op. So Ilizarov with a minimal invasion can achieve a very good functional results in such type of scenario. And apart from that, if you are dealing with poor skin condition, you can go in very early, before 10 days, and get a reduction. And open fractures, see, for open fractures, I'll just go through some basic principles. Debridement and removal of all loose fragments is one of the things. Loose fragments is like which has lost soft tissue attachment. Now, this is a very, very loose term. Soft tissue attachment totally loss is simple to assess, but fragment with a flimsy soft tissue attachment in a high velocity trauma is as good as a fragment without blood supply. So I'm a bit radical on that side. I remove all those doubtful fragments also. Assess the gap, whether it is unicortical or circumferential. Any unicortical gap less than 50% can be dealt with bone grafting. And if it is more than 50%, I go for transport and cover. If there is a circumferential bone loss, transport with STSG is the protocol that I follow. So I'm not going into open fracture much details. Now just with this thing, I'll just enumerate the common problems that we face. One of the commonest problems people complain or patient complain is pain. Now, how to avoid that? And the simplest way is a proper pin placement with as much soft tissue tethering, avoiding tethering as possible. Tensioning, proper tensioning, because as a budding Ilizarov surgeon, people are not having, say, good equipment, and tensioner is a very basic equipment for Ilizarov apparatus. And if a tensioner is not functioning well, you are under a pseudo effect that you are tensioned it well, and the tensioning is not happening properly, these patients will report a lot of pain post-operatively. And another important thing is frame balance. Now, frame balance is a thing which you learn as you do more and more frames. This is like tensioning the frame equally from both sides, medial and lateral. In this way, you can create a balance. Secondly, without deviating any wires while tensioning, you create a good frame balance. So if a frame is very much well balanced, the pain would be lesser. Pin track infection, again, a very common problem. Loosening of wires in osteoporotic proximal fragment is also very common, but as soon as you diagnose this, you reinforce the frame, change the wires. You don't allow the patient to walk with the loose wires. Otherwise, you can get many other complications like even a synovitis or septic arthritis or loosening of the deduction, many other things, sometimes going into osteomyelitis also. So loss of reduction, delayed loss of reduction, especially over a diaphragm fragment can happen. Now, I'll just like to enumerate this thing. You don't worry about this too much, because loss of articular fragment or a diaphragm reduction will only affect your result if your basic anatomical alignment and the stability is not good. If your basic anatomical alignment is good and your knee joint is stable, even up to 1 centimeter, the studies up to 10 mm of depression will not affect a functional result. So what is important to us is a functional result and not a radiological result. So sometimes patient will come to you that this is not a good reduction, this is and what will happen to me? But functionally, sometimes it doesn't affect. Delayed union and non-union can especially happen in very high velocity close injuries, where the high energy dissipation can lead to loss of blood supply of the fragments. Then premature frame removal can happen by misjudgment of the union or by insistence of patient and surgeon coming under pressure. Persistent loosening of the frame can also give rise to delayed union or non-union. Now, this is the only comparative study between an internal fixation and a circular fixator, the Ilizarov Fixator in bicondylar fracture, done in a Canadian trauma center. And if you see the complications and reoperations in open reduction category, there are almost 37 complications reported in 40 patients. While in circular category, only 16 complications were reported. Another thing, return to the pre-injury activity. In a high velocity trauma, in open reduction, only 1 out of 36 patients returned to original activity, original function. And in circular fixator, 8 out of 40 returned to the original activity level. So, in conclusions, restoration of osseous anatomy was no different in both the open reduction or circular external fixator, but there was a 17% infection rate in open reduction. There was higher reoperation rate in open reduction, and there was a circular external fixator. There was faster recovery from injury, a shorter hospital stay, to which I don't agree. I try to keep these patients under observation till the soft tissue settle. And the more soft tissue injuries identified and repaired in ORE, they tried to repair many soft tissue injuries in ORE. But no patient in circular fixator required secondary procedures for cruciate or menisci. This was the comparative study of Canadian trauma center. So what we can understand in a high energy upper tibial injury sector 5 and 6, to give optimal result, what we have to aim for is a straight leg, well-aligned leg, a stable knee, and an absence of complication. Probably absence of complication is almost a battle won in upper tibial trauma. And artificial reduction is important, but it is not as important as it has been glorified. So we have a Oscar-winning godfather, and in Indian Sarkar, we import, we imitate implants. We learn the techniques as the West teaches us. But the protocols for treatment, we have to design as per our system, as per our setup, and as per our economy. With this, I thank you very much for inviting me. Thank you. I'll stop sharing my screen now.
Thank you. Thank you so much, Patel Sahib. It was a wonderful lecture from your side and giving a basic idea to the group and everyone who is attending, and will be helpful at least a basic idea and a basic course surgeon would try to do a simple fracture with the lecture you have given. Thank you so much. Thank you so much. Shamshul sir, if you want to say something or any question.
Thanks, Ajit sir, for a wonderful, very precise and very elaborative lecture. That will be very helpful for all the PGs, residents and young budding laser surgeons. Very, very helpful, sir. I just have a few basic questions that will be helpful for the youngsters. Number one, sir, because in the Shyam fracture, we put the rings very close to the joints. So what is the protocol about the range of motion? How much is affected according to you? And do you plan to span the joint, proximal ring, the distal femur also, or just leave it like this? This is my first question, sir.
Sorry, I missed your first spanning the joint.
Also.
I already said that once I do a below knee fixation, I reassess the instability on table. And if the instability is gross like the joint is subluxating mediolaterally or anteroposteriorly, then I cross the joint. There is an instability, very little, just opening of the joint medially and laterally. I just use traction as a mechanism. I don't cross because crossing the joint, it adds the complications of its own. And probably the most commonest complication of crossing the joint, even if you fix it for say 4 weeks or 6 weeks, at least 6 weeks, people keep it across. And stiffness of the knee is the commonest thing that we face. So what I do is I assess the instability. I know that is a soft tissue injury because Sajgars 5 and Sajgars 6 type of fractures without soft tissue injury is not possible. Now you have to give that soft tissue a rest period, and that is how I use a mid-path regime of traction in these patients to allow the soft tissue to settle and prevent the complication of stiffness. Thank you, Shamshul.
Thank you, sir. Thanks for the wonderful reply. So this is very important that the most common complication is the range of stiff knee and decreased range of motion. So we have to try if possible to leave the spanning as possible. Sometimes in my cases, what I do, I use a 5x rings, and just to add on, I give drop wires to give the anti-rotational stability. That gives a very good range of motion in these cases. And my next question is, sir, what is your weight-bearing protocol for this fracture, sir?
Weight-bearing protocol will depend on how much comminution I am handling at articular level. But right, usually it is after 6 weeks, and it starts with 20% of weight bearing, and gradually over another 6 weeks it increases to full in weight bearing. But if it is less articular comminution, I may start at 4 weeks. But before weight bearing will only start after the patient has good quadriceps, the patient is doing active SLR, and a very less intra-articular comminution at around 4 weeks, more intra-articular comminution by around 6 weeks.
Thank you, sir. That's a very important protocol we young surgeons must learn. And another question for the young person, sir, do you use all wire or a hybrid pin and wire fixation, sir, for these cases?
At upper tibia, upper level, I usually use all wires. Sometimes at shaft level, I may use shunt spins, and middle link, I may use shunt spins and the distal link. But at upper tibia, at comminution level, I always use all wires.
Last question is, sir, for the reduction, do you ever need the use of, besides olive wires, have you ever used the CC screws for reduction or not, sir, besides the olive wires?
I have used it, but I think that using a CC screw, as probably the Canadian study also said the same thing, that using the CC screw probably added to the complication rate in the Ilizarov Fixator. So when those patients where they had not used any CC screw and only wire reduction, they had lesser complications. And I try to follow that. Very rarely I may use a CC screw, very rarely.
Thanks, sir. Thanks for a wonderful presentation, sir. I think NS3D servers here. It's not corrected. Ready, sir?
Thank you.
Hi, Patel. Hello.
Yes,
hello.
Reddy, how are you? Thank you.
Fine, Patel.
Yes,
Hi.
yes.
And one complication which is now and then, not it's a rare complication, but septic arthritis.
Yes.
Of the knee joint.
Yes.
Yeah.
Sometimes what happens is while we are putting these subchondral wires, even if you try to remain as much away from the capsule, you may be very near to the capsule or you may have pierce. But the best way to prevent is that is that you put more number of wires. So the chances of loosening of those wires is less, at least 5, sometimes 6. And you have to be very vigilant about wire loosening. As soon as you find that wire has loosened up, you don't wait for long, you change those wires. Because as soon as those wires loosen up, they will catch some infection. This infection will gradually keep on increasing. And it may initially go for chronic synovitis and sometimes chronic septic.
What you'll do with the hematoma, meaning joint fluid?
In an acute scenario, when I am fixing on day 1, I'll do a aspiration and then I start my fixation. But sometimes by irritation of this wire, sometimes a chronic synovitis may happen at a later stage also. If I find that, then I'll try to identify a wire which is irritating. I change that wire and again do aspiration and put them on an antibiotic protocol for at least 10 days.
Okay, right.
Any other question from the audience or the colleagues? Okay, thank you, sir, and thank you for the weight bearing protocol, because the people fancy that putting in Ilizarov you can start immediate weight bearing. So that is not always the case. That one should realize, and be all, because in a fracture and upper tibia we need articular congruency to get consolidated. And people sometimes they argue, oh, why are not weight bearing? Why are not weight bearing? So that is the phenomenal and basic fundamental in a fracture and a transport. Both are a different scenario, and thank you that you have explained.
Kuldip, I'll just again try to emphasize why this protocol, because Shaurya 5 and 6, Shaurya 5 and 6 injuries, as I said, are always associated with soft tissue trauma, and a severe soft tissue trauma and a severe articular trauma also. Younger the patient, more is the articular trauma. So that articular trauma gives rise to inflammation. And if you try to weight bear them initially, not only they are unstable, but the articular cartilage is inflamed and you may create more damage. So it is better to, and there is nothing is lost if you start mobilization after. And always I see to it that the quadriceps stone has regained, patient is able to do active SLR, and then only the weight bearing protocol is.
That is what I also believe, sir. Let us wait for the upper soft tissue and the proximal fragment being healing, and then it is going to get weight bearing. There is no doubt. Early weight bearing and loss of articular congruency, rather to keep a weight for a 3 weeks or a 6 weeks, as you said, is not going to harm. Even the ROM range of ROM will also add on our Sarmentios principle of that articular regeneration. So that is okay, not the weight bearing only. Yes.
I can see Dr. Amar Soni, Dr. Ravi Chauhan. We like to have their inputs. Dr. Amar, Dr. Ravi.
Sir has elaborated excellently the upper end tibia fracture, and I do use Ilizarov quite often in such complex injury. And the talk was very helpful, and we are glad that sir has found good knowledge on this. Thank you, sir.
Thank you, Amar.
Thank you, sir. Thank you, sir.
Thanks, Shamshul. Yeah, it was really nice presentation, and Patel sir has taken care of all ifs and buts about the basically technical principles of Ilizarov, how to deal with this. But sir, I have one question regarding the very basic debate of using internal fixation versus Ilizarov in 5-6 Shaurya, because a good trauma surgeon or a trauma surgeons, they are mainly in the favor of this, and the Ilizarov surgeons, when we know both the things, then we are in more bias towards the Ilizarov kind of things. So as you have very well explained about the complications and as well as about the study, that's the only study that you have about the JBJS. So, what's your take? Where you find yourself to stand?
Yes. So Ravi, your question is very pertinent, and more younger surgeons who come out of medical colleges, who have been undergone the training of plating, MIPO plating, and posterior column concepts and all those things.
Yeah, exactly, sir.
To them, my answer is like, see, whatever classifications we are taught, all these classifications are basically geometrical classification. There is no classification of soft tissue in there. And all the complications that happen is because of soft tissue in there. So there are now two things. So if you are going to decide your treatment protocol only by Schatzger 5 or 6, then probably you may go wrong sometimes. So what I try to tell them is that you decide whether you are dealing with a high velocity trauma or a low velocity trauma. Don't see to it as a Schatzger 5 or Schatzger 6. And
Exactly.
how do you decide whether it is high? It is depending on the soft tissue trauma that you are assessing clinically. So it is all clinical judgment on day one, whether you are dealing with a high velocity trauma and a low velocity trauma. If it is Schatzger 5 and 6, but a low velocity trauma, you are going to go through with internal fixation, probably without complication. But if you same patient, Schatzger 5 and 6, with a high velocity trauma, the chances of you landing in a complication are very high. In those cases, Ilizarov would be a better option.
I think 10 years down the lane, we can say that this is the ideal treatment for 5 and 6 high velocity trauma, sir.
No, I'm just putting 5 and 6 as a reference, but
Yeah,
I
exactly.
don't think 5 and 6 should be a reference. The reference should be the soft tissue trauma. And
Exactly.
probably down the line, we will be getting grading of soft tissue trauma also, not only on clinical judgment, but on a MRI also. That where to, even if it is Schatzger 2 or 3 or 1 or 4, if a soft tissue trauma is of a high velocity kind, then all those patients are likely to get more complications with internal fixation as compared to Ilizarov.
Definitely, I also feel myself also at comfortable side with the Ilizarov as compared to the internal fixation. But a lot of youngsters and a lot of trauma surgeons, they do have these questions that what's the threshold basically of moving into Ilizarov or moving into like that? Because sometimes when we don't know that particular technique, then we are more prone to do the internal fixations as compared to the other people. Thanks a lot, sir. But it was a very nice talk, actually. Nice talk, sir.
Dr. Parmar, what is your protocol for spanning the knee?
So I do span in some cases, but I don't span for more than 3 weeks.
Exactly.
And in some cases, what I have done is put a Ilizarov device for initial period, and once soft tissue settles, I do go for internal fixation. Means I have done such hybrid fixation in some cases.
Perfect. Thank you.
Okay.
Okay. Shall I start, sir? My case.
Yes.
Yeah, please, Kuldip, go ahead.
Yeah. So, Ajit, sir, if you have continued sharing, you can stop if you are on sharing. Sir.
No, I already stopped sharing.
Already stop.
Okay.
Okay.
So, my case presentation for myself, Dr. Kuldip. I am practicing in Rajkot since last 4 years. And my case is a young 22-year male, had a closed upper tibia fracture along with a popliteal artery injury. So he was treated initially with the screws for a fragment reduction and fasciotomy to come out of a compartment syndrome and artery repair. And after 1 month that they presented to me with this. So it is a mal-reduced, and one can appreciate, okay, average articular surface is there, but there is a spike that is going posteromedially, and that have probably endangered and damaged the artery, and that had to go into the reduction. The external fixator could have been put better with the 2 anterior or the medial tibial screws and the femur screw and good spanning, but that was not done. And at 1 month that was presented to me now. I had to do something with that. So I could not span the knee because I didn't feel the fragment was long enough. So I put in a distal femur ring along with the upper tibia ring and 2 distal tibia ring. And I put in a subchondral CC screw, kept in a subchondral CC screw to get articular reduction. And below that I put in a ring. I was lucky that I didn't had that infection with the internal fixation. was that. And here I used Ilizarov frame as a reduction tool because the fragment one can see that has gone posteromedially in upward direction. So that was the skin condition, the fasciotomy and STG marks. That was a post-op. So I went with the 0.5 mm distraction rate, so no as to damage the repaired vessels. Because that was more worrisome to me rather than a fracture. So I went with just 0.5 mm per day. And then at 60 days, gradually I was going the way I was on the every follow-up. I was checking that foot is okay and the vessels are working. And at 60 days, I was okay. Now the fragment have come down. I will open and I will reduce it. And if necessary, I will put in a bone graft. But on table, when trying to reduce, I was not able to reduce that anteroposterior sagittal sac. I tried hard and hard, but I could not. Then I had to do a vertical osteotomy. As you can see, the wedge which has a base posterior and the line marking. And I did that anteroposterior cut to the separate that wedge and use the proximal upper tibia fragment as a buttress. So I put in a titanium, I think distal radius plate and cut that bone piece posteriorly, and in a hope that soft tissue on the posterior aspect are there and it will work as a live bone graft. So I kept it posteriorly and put in a plate, and that reduction was good. I had to just do a mini incision and that reduction was there. So I still kept the Ilizarov frame as a other plates. So here I used it as a static frame and not the standard transporting or reduction tool, but as a if this would have been a simple fracture, then it could have been a 2 or 3 plate, but I keep as it is the frame as to give a support to the fixation by plate. And after probably 1 month later on, I removed the femoral ring and start mobilizing the patient. And I was lucky that he gained 90 degrees of range of motion. He has an anterolateral and posteromedial fasciotomy marks, probably the muscle loss. But at 6 month follow-up, he healed well. Even can appreciate the healing. The posterior bone mass is there, but that was not an articular fragment. So I was okay. That's okay. And he is walking well. He has high stepping gait because initially the muscles was not as great. He might have had anterolateral muscle mass trauma. But at 10 months, 4 months down the line, one can appreciate the gait has improved. He's walking well. Yes, the brace is for just a safety sake, and it is not as much helpful. And the patient have got 90-degree range of motion, which I was not expecting. Happy with the case. I'm done, sir. I'm done.
Yeah, thank you. You can unshare. So thanks, Kuldip, for a wonderful hybrid fixation. It's a very good method of distraction and along with plate fixation, because if you had waited on Ilizarov, it would have taken a long time. So this is a very good plating after Ilizarov. That is for plating after Ilizarov or second fixation. Dr. Parmar has been doing a lot of these cases.
Yes.
Yeah. Any input from Patel sir or Amar sir? Dr. Amar, because we have seen you putting plates on distal femur proximal tibia.
Yes, yes. In femur, I am having large series where I have done hybrid fixation. In tibia, I am having very less cases. But I do, but not simultaneously. I remove frame and I apply a locking plate.
So if this was your case, what you have done similarly or different?
I would have tried to reduce that sagittal plane malalignment with hinges and washer. So gradually that would have come out and that would have aligned the fragment, sagittal plane malalignment. Probably. Yes.
Patel sir.
Yes, Shamshul, what I would be doing differently in this case. what I will be doing, first of all, since this was a vascular injury to start with, and probably a vascular repair was done, I will be, if this case comes to me, I'll again go for a CT angio to know the status of vessel and the course of vessel before I start applying a distraction. And as he has gone above the knee, I try to see through it that I try to remain below knee, try to distract and get a distraction as he has achieved. But when I'm doing this distraction, as I have emphasized, that all these fractures have a lot of posterior soft tissue injury, a posterior compartment muscle injury, and they do give rise to a lot of equinus, a very rigid equinus. So I, instead of going above knee, I'll try to put a frame in the foot. Whatever equinus is there, I'll try to correct gradually. The equinus is going to increase with the distraction. So I'll try to not only correct equinus, but prevent further equinus by putting a foot frame. Once I have achieved that, and if the CT angio is showing the course of the vessel okay, then in lateral plane, I will translate it gradually, because this is not only translated, it must be a rotational malalignment also between the two flags. So it may require a rotational alignment and a translatory alignment. So that which can be done with a translation rotation device, what they call as a Baltimore device, we can apply that device and get it easily in the between the first and the secondary. And probably I would have avoided open reduction and excision of the bone and try to achieve anatomically as much close as possible. But having said this, with a caveat that the course of the vessel is such that it doesn't come into the way of fracture while I am reducing closely. So that has to be pre-operatively decided, the course of the vessel.
Thank you, sir. Thank you, sir. So the list for the youngsters that we can do it gradual distraction, gradual correction, putting on a plate, or as Patel sir and Dr. Amar said, we can do gradual translation, that is ideal and Ilizarov fixation. And then we just decide we can just fix it or not. So very good case for the youngsters in learning. So over to you, Kuldip.
Yeah. So that is why I was thinking that yes, I have distracted well. Now I will be able to reduce on it. So that's why I just opened it. And as I have opened it, I went in and I tried also to disengage that fragment spike. But then I realized, and I knew from the day one that it was a vascular ripple. I don't want to juggle it much. So that on table, this was an on table decision. I had to wait for a plate to come and plate to come. It was an on table decision. But yes, ultimately the faithful and the thought process that the posterior segment is well vascular, it just need to dissect it and it will act as a posterior graft. So that was an on-table thing. I had to wait for the implant to come and get autoclave, and then I had applied it. I was not at all prepared for that. But as I had opened it, I put in a plate. Otherwise, in a closed manner, as Ajit sir and Amar sir has said, that can have been done.
So it depends on the surgeons and situation comfort. That's very important. Dr. Ravi, you are there.
Yes,
Dr.
sir.
Dr. Akansha, is there any inputs?
I may add one point, Shamshul,
Yes,
that pre-operatively in such cases of vascular repair with a posteriorly displaced proximal end of a distal fragment. Now, when you receive such cases, if you are not going for CT angio, you can also go for a MRI. MRI will and do a MR angio. So you will both get information of the soft tissue status. There is a buttonholing of the fragment into. So whatever probably why he went into after distraction trying to do for open reduction, he would have gone for that MR. He would have realized that this soft tissue, it is very difficult to get it out in acutely. It can only come out gradually. So sometimes I go for MR to see how much posteriorly the fragment is buttonholed into the posterior soft tissues.
that is a very important point, sir. Yeah.
That is a learning point. That is a learning point. One more investigation would have been helpful. Yes.
You save your own limb.
So can I address the new speaker, sir? Or
We don't have any more questions, so we can go ahead.
anyone want to ask? I'm ready.
Any questions from the panel? No.
Okay, so the next speaker from our group is Armish Soni. He's practicing in Junagadh, working fantastic Ilizarov, and he's a fellow of Dr. Amar sir and doing good Ilizarov. I would request Armish to present his case. Unmute yourself, Armish. Armish, unmute yourself.
Yes. Are you able to see the screen, sir?
Yeah, perfect. Go to the first slide.
Yes.
Okay. Good evening, sir. I am presenting a case of grade 2 comminuted fracture middle third tibia fibula with Ilizarov technique. Okay, here is a 21-year-old male has sustained a road traffic accident, which was a high velocity injury, and he got open grade 2 comminuted fracture middle third tibia and fibula. These are all the strategies we can put in the mind. We can put an Ilizarov, we can do MIPO or expert tibial nail. We can retain fragment or remove it. In Ilizarov, shall we do single or dual corticotomy? I have applied Ilizarov. I have degraded and removed all the loose pieces. I have refreshened the bone ends and put a frame with dual distal tibial corticotomy. The resultant gap was around 10 centimeter. After a latent period of 1 week, I have started distraction at a rate of 1 mm per day at each corticotomy with a rhythm of 0.25 mm 4 times a day. At fracture site, I have started compression of 0.5 mm 4 times a day. These are the images during transport. You can see both the corticotomies are equally distracted and the fracture site is getting compressed. This is called the tandem trifocal transport. At 2 months, docking stage was achieved and skin invagination you can see in the clinical picture. I have done the open docking, and at 8 months, the fracture site was healed and no abnormal movements were seen at the clinical testing. The regenerate was hypertrophic, but due to compliance issues of patient, he insisted for early frame removal. At 8 months, we have removed the frame and regenerate was protected in the cast. At 10 months, cast was removed and we can find the good consolidation of the regenerate. At 12 months, you can see all the fracture was united, the regenerated was adequately consolidated, and there was no shortening and good functional activity was seen. This is a post-op gate video after removal of frame. Ultimately, at 10 months, at 1 year, there's 10 centimeter defects was there. In 8 months, frame was removed. Healing index is around 30 days per centimeter. Fracture is united without flap cover and bone graft. Patient has least morbidity and minimal stay in hospital. Due to trifocal osteosynthesis, the frame time was significantly reduced. There is no limb line discrepancy, and patient was walking unaided, and he returned to pre-injury occupation. Thank you.
And Dr. Armish, can you just go to the transport frame? Can you show the transport frame?
Yes, sir. Yes, sir.
The practical transport that you are doing the initial, say, after this one, before this one. Yeah.
Yes.
So see, there is a division of the second fragment, the proximal. Yeah.
Yes, yes.
So did you try? I think just 2 wires in the second ring. Did you ever plan to apply drop wires, one above or one below? So
Yes.
that.
We can put a drop wire. I have put one K wire and one shunt pins at 90 degree. There was some deviation, maybe due to less stability. We can add a drop wire and give additional stability.
That is a very important point in long transport, in the traffical transport. So we can, the second and third fragment, we can apply one above and one below drop wire, so that is very stable and ultimately gives a very good fixation and consolidate as well. Thank you.
Yes, sir. Yes, sir. Shall I stop sharing screen, sir?
Now we can have question from the panel.
Was there a,
Yes.
Armish, there is a question from Aradhana Rathod. She is asking, was there a compression on the first ring? So first and second ring was under compression or what?
Yes. After transport, after docking, I have compression. I have compressed at the rate of 0.25 mm 2 times a day at alternate day.
Okay. So proximal ring is you were rotate. The patient was rotating nut on the proximal ring.
He was rotating nut at second ring for compression. Yes.
So
For
it is
compression.
ultimately the corticotomy is which is going near to the fracture.
Yes. The transport fragment will go to the fracture site.
Yeah. As you said, compression, the fellow could have understood that that could have come down, but that will damage the tibiofibular syndesmosis, and that hurts. That is more desirable in, I think, femur, where one can go with the compression and one can go with the distraction at others. Because that is a single one. Here we have to deal with the tibia femur and both the syndesmosis.
Yes.
Any other question? Patel sir, if you are audible, and they have Jeevan Pareria have asked for rotation and translation. I think devices he want to say, he said distraction. So if you could see the devices, if you have an image.
Immediately, probably it will be difficult, but I'll definitely share with you.
Yes.
Okay.
Thank you. Any other question from the panel or faculty? Yes, sir.
Yeah, I have Armish, it was a nice case basically with the trifocal transport.
Yes,
My question is to Amar sir. Dr. Amar, you must be having a long experience of these long transports. I have seen your cases, very nice cases you present.
Yes,
so
sir.
I want to ask about those migratory fragments or transported fragments, the middle ones.
Yes.
Second and the third segment.
Yes.
So if they are big enough, then except to the ring and its wires, what you prefer? You prefer the drop pins or the drop wires?
Means if you wish to span little bit more, what you can do is instead of using one hole Rancho cube, you can use 2 hole Rancho cube. And you may use one wire, 1 half pin, or 1 wire and 2 half pin. But what my observation is, with 1 medial face wire and a perpendicular half pin, mostly this toggle is seen very less, because there will be a 90-90 spanning. And second thing, that there is no deforming forces in such transported fragments. So whatever deformation we are seeing is mainly due to instability, not because of muscle pull. Suppose the patient is developing suppose equinescence, that is because of pull of tendo Achilles. So in long transport, I would always prefer that patient should have a foot frame. But regarding deviation of transported fragment, if stability is good, it happens very less often. Means one need to address have a stable frame. If frame is stable, then the chances of deviation are very less.
Because what I find also when I'm using the only wires in this long transported fragment, then it is somewhat less stable as compared to the using the wire and the pin. Pin, which is at the 90 degrees sometimes.
Yes. In diaphyseal region, the problem with 2 wire is you will hardly get stability of more than 30-40 degree.
Exactly.
Second thing, with transport, they will significantly affect the excursion of tibialis anterior, EHL ideal, because those wires would be passing through tibialis anterior, while this medial face wire would be inserted in such a manner that it won't affect the excursion of tibialis anterior or even gastrosoleus. So that helps a lot. So the whole frame is inserted in such a manner that it gives pain-free excursion of foot during whole treatment period.
Exactly, that is more important, because that will that also avoids the further deviations also about the fragments.
Yes. And regarding foot frame, we can remove after 6 weeks of docking, because once you have done the docking, then chances of developing equinus afterwards is very less.
Definitely.
Yes.
Thanks.
Thank you.
We have Dr. Amir from Amir sir. Any inputs? Please unmute.
The problem which I also face, that during the transport, there is some deviation
Yeah.
from this way or that way. So if seniors or those Soni or Shamshul or Ravi can explain steps to curb that deviation of the transported fragment, that will be better.
That is actually very important, sir. Either we apply shank spins, as Dr. Amar and Dr. Ravi said, or we apply drop was for more stability, more plane, because that is in a single plane.
But one good point was that, sir, he was well with his proximal tibia frame and
Correct.
distal tibia frame. So overall, his alignment has not changed in spite of that two fragmented.
Actually,
So ultimately, that is the important, that MPTA and LDTA, lateral distal tibia angle and proximal tibia angle, that remain maintained. So the medial deviation is okay, as is, I think, okay. If your proximal tibia and the distal tibia line of a frame is in the same, either in the AP and lateral.
exactly.
That was okay. So probably Armish would not have gone.
Stability and the alignment of the proximal and the distal principal segments is
Yeah,
utmost importance.
Yeah. So that's where he came out, that that deviation didn't affect his case much. So shall I progress, sir, or any question on the faculties or question?
Any more questions? Akansha, any questions? Okay. You can progress.
So for the next speaker, I would like to invite Shaurya Shah from Baroda. He is along with practicing Yogesh Godbole sir, who is again the beginning along with Patel Sahib in Baroda, and they were all working very well. Shaurya, you can go with your case.
Thank you so much. Thank you so much, Kuldip bhai. Thank you, everyone. I'm just sharing the screen. So sharing with you probably the most simple case of all the presentations after all these complex cases. It's an open grade 3B distal tibia extraarticular fracture with bone loss. Just a second. Okay. So the reason I'm sharing this case is it was actually my first surgery as an Ilizarov center when I was freelancing at a peripheral trauma center. Going with the demographics, it was a 28-year-old male, a vehicular accident where he was going on a two-wheeler which clashed with another four-wheeler, and he sustained an open grade 3B injury with two lacerative wounds on the medial aspect of the tibia. As you can see in the picture, the lower wound was the part from where the distal part of the proximal fragment was shoveled into the ground, and that was the main part which was contaminated. As far as the distal neurovascular structures are thought about, there was no deficit. The only thing was that he was a very heavy tobacco consumer. So on day one, the primary surgeon, the index surgeon, he decided to debride it and put a linear external fixator with a rush pin to gain the length, after which I came into the picture for management of this case. And the red lines actually show the margins of the bone excision, which I had decided to go for in the second stage. In the first primary stage, only the loose fragments were removed. So as far as the treatment strategy is concerned, the patient was given options of these two things. Actually, the first is arthroplasty strategy, where the external fixator followed by a flap surgery and a second major surgery of internal fixation and bone grafting was explained to the patient. But the relatives were a little dicey on having a plastic surgery and then an internal fixation and bone grafting and everything. And also the second concern they were having was that they were a little more convinced with the Ilizarov device allowing weight bearing a few days after surgery or as per the patient's comfort. So they decided to go for segment transport and with Ilizarov. So we decided to go with that. We can definitely do a transport with LRS, but honestly, just being a juxtaarticular injury, I thought LRS was a little not good for this case. Also, it's less modular than Ilizarov as far as bone transport is concerned. So I went for the Ilizarov fixator. So this was the configuration that I decided to go with. In the proximal, the first part was a 1.5 ring, where the half ring had one wire and one anterolateral half pin. And the second ring, which was connected to the first half ring with sockets, had two wires, one transverse and one medial face wire, and one anteromedial half pin. The floating segment had two rings, that is the R3, the third and the fourth ring. Again, one medial face wire and one half pin, which would make the configuration 90 degrees to each other. And the last, or the ring holding the distal fragment, had one wire, two half pins and one drop wire from a male-female post. So this was what I could achieve intra-op. The collage basically shows this overlapping images of the fixator. And the reason I also shared this case, as I said, that this was my first surgery. And so applying the fixator and stability of the fixator, which obviously is of absolute necessity. But then when it comes to corticotomy in the proximal part, which was done on the 8th day after the fixation of the apparatus, as you can see, there is propagation of the fracture line upwards and downwards. So I think there's one thing I learned from this case was that less holes while drilling for the corticotomy and drilling the holes proximal to the holes of the previously put external fixator are a little bit dicey, and that can cause a little complication, which happened in this case. The final gap which was achieved after debridement of the fragments distally was around 6 centimeters. We started the distraction in the same standard way at 7 days, and the frame was holding pretty well. Another concern, which was the medial wound, after debridement, we had a lot of soft tissue loss. We did definitely explain the patient that daily dressings or alternate day dressings and SOS, if at all required, if the wound was not healing well, or if it was getting infected, then we would have to go for a plastic surgery, which was again an option for orthoplasty. But the wound definitely healed well, and it contracted later without any complications. So after 60 days, this is the image which was taken like around 50 days of bone transport. And as you can see, the transport fragment has gone a little medially, and there is a lateral translation of the distal fragment. So that was addressed during the docking surgery, and I think it was brought well into place and gradually compressed. So the image on the left is the one which is immediately post-op after the docking surgery, and on the right is the one which was at the time of union. Another complication which I faced during this surgery was there was a pin tract infection. The half pin, which was anterolateral on the first half ring, it got infected. The patient initially did not report as he was actually following up with me from a very distant place. And when he came to me for this, there was a lot of pin loosening. We got an X-ray done that day, and there was a lot of osteolysis around this pin. Also, it was spreading towards the transverse wire of the first half ring. So it was very painful, also restricting movements of the knee joint. So we decided to remove both of them and get the half ring removed from the proximal part. This happened at 5 months after the application of the apparatus. And this is the X-ray just after the frame removal, which shows a reasonably well aligned fracture and axis of tibia. This is the condition of the wound on the left side on the day of injury, and on the right side, the one which went on to heal without any plastic surgery. The scar just contracted well. And this is the walking video. The video on the left, which I'm showing, is immediately after frame removal. The patient was a little apprehensive, and we had put on a AFO type of brace just for the sake of protection for all the holes that he had after removal of the frame. And the video on the right, which I'm about to show, is the one which he sent to me around 1 week back. To summarize, a 6 centimeter defect, 7 months in frame, expected duration for the distraction was 60 days, which in actual went on to 60 days. However, the consolidation period, which was supposed to be 120 days, was extended by a month, that is 150 days. Healing index of 35 days per centimeter, fracture union without a flap or a bone graft, no limb length discrepancy, and return to the pre-injury occupation very happily. Thank you so much.
Very nice case.
Thank you.
Yeah. The last frame, are you sure that the distal docking fragment has been united well? Can you just go to-
Yes, sir. Yeah, I'll just start sharing my screen again.
So you're already sharing. Can you just go to that slide?
Yeah.
Upperly slide.
Yes, sir.
Yes,
Sir,
this
so
one.
yeah, yes, sir. So this one, we were a little concerned about that as well. So what we did was we actually opened we did the testing of the docking site much prior to that of the consolidation site. And the patient till now has not reported any complaint from that. It looks a little dicey, definitely. Actually, we had it examined in IITV under a few oblique views where the posteromedial part has a good amount of union. So I think there's no problem in that.
These are very important points because once you remove, you cannot do it again.
Yes, absolutely. Absolutely, sir.
Patel sir, your take on Amar. Your take
Can
on
you
this?
show the wound for the? Can you show the wound, please?
Yes, sir.
So considering this, it is definitely good job done. Okay.
Yes, sir.
Any thoughts from any others that the amount of bone excised and the wound that showed, would it have been a less amount excised because of, I think, the amount, the bone excised, it was much above the lower part of the wound. It's really how far would have saved, otherwise you're not. That's in retrospect. Okay, I am not criticizing. Okay, done a nice job, difficult job. Just there are several learning points always, I think. Okay.
Yes, sir.
So
So
that's why I'm just comments from any others. Okay. In my mind, it appears that we could have saved much more bones. The transportation could have been less, and what's your thought? Anyone else, please? Senior, please.
Wonderful case. Dr. Aradhana, your input, please.
Sir, I would like to know how much is the ankle movement after the frame removal or during the follow-up? Usually it goes for stiffness. Distal tibia fractures usually go for stiffness.
yes.
So yeah, what was the range of movement?
So, ma'am, the ankle does come to neutral. With a little effort, it goes to 5 degrees of dorsiflexion, just enough for walking. He is not complaining that he has to walk with one limb ahead as a result of equinus or something. The plantar flexion also has, I would say, it is lesser as compared to opposite side. It's 10-15 degrees lesser as compared to opposite side.
Right. Yeah. And there was no necessity to span the ankle. You felt the frame was stable during the...
Yes, ma'am. So after application of the frame, I did check some stress views at the ankle. There was no subluxation or any joint movement per se. And even after application of the frame and walking, the patient did not complain till the end that he had any feeling of laxity or anything around the ankle joint. So we did not span the ankle.
Okay, and you had put one intramedullary wire for the fibula. When was that removed?
So that was put by the index surgeon on the first surgery, which was external fixator application and debridement. It was actually removed during docking because,
Yeah, understood. Yeah.
Yes,
got the point. Yeah,
yes.
Okay.
Actually, what happened is that I would like to show this slide. The red dots which are there in the X-ray, that was the part of the bone that was actually shoveled into the ground. The first surgery was debridement, where these fragments were loosely removed But when I attended and when I opened up a little bit proximally and distally, that was completely filled with mud. So I think that we debrided that day.
Probably your second debridement gave a better result than the primary debridement. Right?
Hopefully.
Yeah.
Yeah.
Yeah. Okay. Yeah.
Shaurya, from my point of was there an open docking or just a translation device? What you did?
No, that was an open docking.
So just a one suggestion: if you are opening, put in a graft.
Yes, yes. Definitely.
That is not going
Definitely.
to harm our people. Yeah, that may not be good for the cosmetic and Western people, but our people will accept the bone graft. And that is to be taken from themselves.
Yes.
Just my advice. It is not always a necessary. People don't use, and that is also right. But if you are opening, why not to just put give 15-minute effort and put in a graft?
Absolutely. Agreed.
Either you just took accordion or you put a graft.
Yeah, yes. Even because distal third tibia, at distal tibia level, the vascularity is always, even with if you see a nailing cases or plating cases, that the vascularity is a watershed level. If I'm not wrong, the Shaurya would say better. He is being younger. It is
No. I agree to that.
Just put in a graph that just one take. It still has united. And his walking has also improved. If you see the latest video, because of his ankle range of motion has also been gained. Yeah, definitely.
The ankle is, I would say it is stiff, but it has improved. I would say.
We can appreciate that there is a dorsiflexion as well as good plantar flexion.
Yes.
Normally in Ilizarov, we don't need to do grafts if good docking is done and a good according is done and a good compression is done. But if you have opened for the alignment, you should give a graft.
He is open. That is why I asked. He is open, then just put in a graft.
So you should avoid opening. And Dr. Amar, are you there?
Yes, sir.
Yeah, you're in, please.
Yes. Hello.
Yeah,
Yes, sir, you are audible.
Means he has done good job, and bone grafting, yes, I agree that if one is doing open docking, one can put the graft. But if bone ends are adequately refashioned and there's good vascularity and patient is fully ambulatory, one may not go for graft, and it will surely heal. But I agree that bone graft is an option and one should use it whenever one is doing on open docking.
It's a very good case. Patel sir, any input? Patel sir is there?
Yes, Shamshul. Can I ask Shaurya to put a X-ray where it showed tetria shoveled and displays?
Yes, sir. Just a second.
See, there was a very important query raised regarding how to decide he has marked these red dots for excision of the bone.
Yeah.
Now, he has also described in history that the distal end of the proximal fragment had displaced and gone into the mud. Okay. Now, what is important is how to decide how much to excise in these cases. How much to excise? Probably Dr. Amir raised this point. So how I decide is, suppose I am a primary surgeon on day one for this case. Still, apart from removing the loose fragments as done by the primary surgeon, suppose I have to decide how much to excise. Then the most important thing is, while debriding, I open up quite long to see till the intact periosteum is seen. So I go till the intact periosteum, and from that point to the tip of the distal end of the proximal fragment, and I measure it, and I excise whatever denuded area of whatever which is denuded of periosteum. I denude up to at least 2 times the diameter of that bone. So if I have to say in this case, what I judge is probably the excision of the proximal fragment to me is bit lesser. I would have done it more, at least half a centimeter or centimeter more, depending on the clinical picture on table. But why is showing probably the less callus as seen at the docking side is because still the vascularity of the distal end is still on a lesser side, and that's why probably that good amount of union callus is not seen. But he's fortunate that he has got away with union, and it has ultimately given a good result. But to me, I would have excised it a bit more till it is more vascular than what it is at this point. But where is marked, probably it would be vascular, but still it would be hypovascular at this point.
Very agree, sir. This is a very valid point for the young.
Agreed, sir. Agreed.
1 centimeter on a good side is better than on a.
It's better to excise more than R on a lesser, because that at docking time it will show that even though it doesn't get infected, at docking side we go for delayed union, the chance the refractures, all those issues can come up.
Absolutely, sir.
So that was the last case. As I said previously, that our lectures will be pretty helpful and not a longer. And if there is any question, the panel is still there, and we will happy to answer them as well.
You can share the screen if there is no question.
Yes, sir. Yes.
So these have been very good cases for the young surgeons to learn the basics of Ilizarov. Especially the lecture of Patel, sir, was wonderful.
So thank you, Shamshul sir. Thank you, Patel sir, Shaurya, Armish. I'm thanking everyone that they took in time. It's been a 1.5 months since I have been engaged with Shamshul sir and all of you, and taking your time. And I'm thankful that you made I think that is helpful for a budding Ilizarov surgeon lecture. If I am not wrong, Shamshul sir.
Yeah, thank you. Thanks, Kuldip, for a wonderful arrangement and very good cases. Your it's a real words are very good, and we'll be expecting more from you in coming months. And from all the,
Sure,
yeah,
sure.
and maybe expecting one from Aradhana from her state also.
Yeah,
Yes.
yeah, I'm planning, sir. Me and Rizwan sir are planning some nice stuff. Yeah, we will do that soon.
And one from BIS from West Bengal by Amir sir, since he's here.
Sure.
So thanks everybody, and see you the first Friday of October and 6th of October, the master class on limb lengthening. Dr. Mangal Prahar sir and Michael Asraj from Baltimore will be speaking on tips and tricks of limb lengthening. So see everybody, see you all. Good night, and thank you for coming. Thanks a lot.
Thank you, sir. Thank you.
Okay, sir. Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Okay, sir.
Thank you.
Good night.